Hello, everyone, and thank you for joining us today. My name is Natalie Boyam, and I am the president and founder of the Defeating Epilepsy Foundation. We are a 501c3 not-for-profit in Southern California, and our mission is to provide the advocacy and educational resources needed to the epilepsy community and our society. Today, our guest is Ian Bone. Ian is the author of Sacred Lives, an account of the history, cultural associations, and social impact of epilepsy. Ian has been a consulting neurologist for over 30 years now and has a son who is battling epilepsy. Thank you, Ian, for joining me today.
Thank you, Natalie. Thank you for having me.
Today's discussion, we are focusing on the challenges we are facing on a global level when it comes to obtaining good health care. The United States has focused on a for-profit system for many years, doing what they can to prevent a Medicare for All program. In the United Kingdom, leaders are working to try to establish a similar system, claiming that it cannot continue with the current NHS system. We have seen over time the deterioration of healthcare, with profit being put over quality of care in some situations. Dr. Bone, what changes have you seen in recent years that concerns you when it comes to patient care?
I think maybe, Natalie, just to set a little bit of background to start with. The National Health Service is 75 years old this year. And the National Health Service came in after the Second World War as part of an enormous amount of social reform. And what the National Health Service committed itself to was to provide care at the point of need to all of the citizens of the United Kingdom, that there was to be no cost, no one was to pay. Needless to say, the opposition to this, sadly, came from the medical profession initially, because they saw this might be a loss of their autonomy, a loss of their earnings, and also that they were basically becoming state employed. And that has had a long-term effect, because if you look at the income of doctors in the United Kingdom, all state employed people are subject to pay review bodies that look every year at salaries and decide whether to increase or whether not to increase. And the reality is in medicine in the United Kingdom, the salary of the hospital doctor has dropped over the years because pay has either been, well, it's been below inflation for a long, long time. So there is a lot of unhappiness in the profession, which has had an effect upon recruitment, both for doctors and nurses, and all staff that work within the National Health Service. And this has resulted in a gradual move away, a gradual reduction in the numbers of people that work. So to answer your question in a rather roundabout way, at the moment we have about 10,000 doctors short of what our national requirements are assumed to be, and a shortage of about 40,000 nurses. The biggest shortages are in primary care. And primary care is where people with their epilepsy in the United Kingdom would go and get their prescriptions, would go to be reviewed from time to time, as well as also being reviewed by the hospital service. So this erosion that we're seeing in the numbers of people working in primary care has had a major impact upon the quality of care that we offer. If we go and see our general practitioner, our family doctor in the United Kingdom, we usually see a different doctor every time we go because there's a constant turnover of staff. There's a study in Norway that goes back to 2002, where over 10 years they've looked at, they basically randomized people into those that would see the same doctor every time they went back, and those that would see the available doctor every time they went back. The results are staggering. After 10 years, mortality figures are lower by about 30% in those that attend the same doctor every time they go. Drug prescribing is reduced by about the same amount, and emergency admissions reduced by about the same amount. So our problem in the United Kingdom is that the shortage of doctors, the shortage of nurses, means that we just don't see the same person every time we go back to the service. So the person that we're seeing doesn't know us, and the consequence of not knowing us is that when we go back, we have to repeat the story over and over and over again. Now, another thing that's happened, and again, particularly pertinent to epilepsy, is that if we're attending a hospital service with epilepsy, we go to see one neurologist. If we're unhappy, and we'll wait many, many, many months until we see that person. When we see that person and we're unhappy, say, with their management of our epilepsy, we're allowed one second opinion. But in the National Health Service, it's not possible to be referred to a named neurologist. So if a friend of yours says, well, my epilepsy has been looked after so well by Dr. B, and you say to your family doctor, I would like to see Dr. B at the hospital, the family doctor will say, well, I can only refer you to the seizure clinic, and you get to see whoever you get to see. So the biggest challenge, I think, the biggest problem is this lack of continuity of care, fragmentation of care, and that lack of continuity and fragmentation results really in a less satisfactory delivery of healthcare to the individual. And in a long-term condition like epilepsy, there is nothing more important than continuity and trust. Seeing the same person each time you go and seeing a person who you trust to look after you.
Oh, that's absolutely true, because I can say I was lucky to get the neurologist I wanted. Now, he wasn't in my network, but the two doctors were in my network. The first one I had a real bad experience with, and the second one, his reviews were 1 out of 5 stars. Just hold down the list. And I told my doctor, there's no way I'm going to see someone like that. So I was very lucky at first, the medical group, because what we have our HMO, our health management organization that we pay our premiums to, and they manage most of our records. But depending where you live, we have what's called a medical group. And in that area, they will have a network of doctors for you to choose from. And it's very rare that they will allow you to see someone out of the network. But when I called the HMO and said, look, I don't want to be in and out of the hospital. I don't want to be put on a bunch of medication. I want to work with someone I can trust, keep my health care under control, and see them a couple times a year to make sure what I need is there. I pretty much want to be a cost-effective patient. The moment I said I don't want to be this big expense to them, to please just give me the opportunity to work with someone, they went along with it. But just the thought of not being able to choose my doctor, and if I have a negative experience, that I may not even get a second opinion. I mean, that's scary. I can't imagine what that feels like for anyone with epilepsy or any type of chronic illness. And the fact that, when are you going to get your medicine filled and everything? That's pretty scary to hear, that there's that lack of lack of service, lack of insecurity because of what's happening with the system. I mean, over here we are starting to have a shortage of people as well, and that's mainly due to the stress COVID has had, with about 1/3 of our country is refusing to vaccinate, which is making trying to get this pandemic under control. It's had such an impact on it's divided our country. It's had a negative impact on our economy and a negative impact on our healthcare system. And with education not being free here, to become a doctor or nurse can cost hundreds of thousands of dollars. And a lot of people are at the point where, why would they want to get hundreds of thousands of dollars in debt when this is how the outcome's going to be? It's really the bonuses they're offering and the incentives they're giving to people just to get them through the training and into the hospitals. It's unbelievable, but it's at the point where it's gotten so bad where it's still not enough in their mind and they're turning away from it.
One way, I've spoken about the National Health Service, but if you do want to see the neurologist of your choice, that is possible by going privately in the United Kingdom. So what we're seeing develop is 2 levels of care. We're seeing the level of care that the National Health Service provides and the level of care that the private sector provides. And what's increasing is the number of people going privately to get round all of these hurdles. One issue with the National Health Service is, okay, it's free, that's great. Even though you can't get to see the person you want to see, at least you get to see somebody. It's free. But the problem is accessibility. And that is, the number of neurologists, the number of epilepsy specialist nurses, the number of people there to see you is small, and therefore the waiting time to see them is very significantly long. If you're referred here for a neurology appointment in the west of Scotland, you might wait 6 months to see somebody.
Oh, wow.
If you have epilepsy and you need to be seen on a recurring basis, you may be seen once or twice a year. You may see the neurologist the first time you're seen. You may see the epilepsy specialist nurse the second time you're seen. And when it comes to COVID, again, the huge impact on COVID on our hospital service, because it's undermanned and underbedded, is that our NHS for the last 2 years has been dealing with COVID. And as a consequence, with a population of 70 million in the UK, we have 6 million people on waiting lists for operations or to see hospital doctors. Wow. And that is going to take, I think people have worked it out, that it'll take until 2025, at least 3 years, to work off that waiting list. So you've got people waiting for hip replacements, knee replacements, people waiting for pain clinic appointments who are having to wait months and months and months. And the only way that they can get around that is to then opt to pay to see somebody privately. So COVID is pushing us towards a situation where we're going to have 2 levels of care: private sector care, public sector NHS care.
Yes, and that's very similar to what we have. We have what's known as Medicaid, and the only way to get Medicaid is you pretty much have to be one step away from homelessness or completely disabled to qualify for it. The rest of it is private care, or in some situations, what some states will do is they will have an assisted program where you pay so much into it, and then the rest of the year it's free. It gets covered by the rest. But even in other parts of Europe, Germany, where my in-laws are, my father-in-law did the same thing, even though their social health care covers a lot of stuff. When my father-in-law developed diabetes, he was not comfortable with the doctor he was assigned. So they purchased a private policy for my father-in-law, which gave him a much wider range of doctors he could choose from and hospitals and services that he would have access to now. And, I have empathy for people who have chronic illnesses, especially as the age, and it's harder to maintain good health, because they really, to me, it's an unnecessary expense. We shouldn't have to, at that stage in our life, after working hard and doing the right thing in life, to have that kind of an expense after we retire, with so many people who are elder having to be on a tight budget.
Yes, absolutely. Yeah. Yes, I don't know what solutions. I mean, when we look, I don't know what's happened in the United Kingdom. We have our National Health Service. It's paid for out of our tax. But there is no ring fence tax. We don't pay a tax for healthcare. We just pay our general tax. And that money is then divided up with defense, education, overseas development, health. So it's divided up into various areas. And our government have ministers in each of these departments who will fight for their own budget. So the Minister of Education will be fighting for a new school building program against the Minister of Health, who will be fighting for a new hospital building program. Now, when it comes to health, we pay less of our GDP on healthcare in the United Kingdom than most European countries. When we look at staffing, I think we have one of the lowest levels in Europe of hospital doctors and family doctors in relation to population. And the same thing applies to nursing. We have very low levels of nursing compared with other European countries. other European countries, whether they're funded through a healthcare system that is run by the state or one that's combined with a private health insurance scheme, whatever they do, other European countries generally spend more of their GDP on healthcare than the United Kingdom does.
No, that makes sense, because I think that is the situation in Germany. I know that the one chancellor before Merkel made a lot of cuts to the programs and things that over here, I don't know about in the United Kingdom, but things over here like dentistry, a lot of even if you have some level of dental insurance, you still have to pay to a degree for some level of the service. And I remember years ago, my mother-in-law was angry because it was the first time in her life she had to pay to have her teeth cleaned, and just didn't get the impact of, how lucky she was all her life to be able to that point, have a free service to keep good oral hygiene. And I told her, I said, Mama, over here, dental care isn't a right. It's a luxury. I said,
Yes,
that's
yes.
why your son has a job as a periodontist, because there's so many Americans who never see a dentist until the point it's so bad their teeth are falling out. And my husband's job is to try to save them by doing bone grafts, gum grafts, implants. And sadly, especially with COVID now, he's told me he's been sending more and more patients to get dentures, and he feels so bad. He just the other day, he sat down with the patient and said, I wish I could help you, but it's at the point where even if I tried, the probability of me being able to save anything, it's
Yes,
little to
yes,
none.
yes,
And so
yes.
many patients are just so upset that they're losing hope in the system.
I know. Can I come back to one thing you said too? You mentioned about the cost of becoming a doctor or becoming a nurse in terms of the fees that people have to pay to go to university. I was of an era, and again, this was part of the welfare state. When I was a student, we paid no fees. Our education was free. So we paid nothing. We had a maintenance grant to actually allow us to feed ourselves and to find lodgings to live in. And the maintenance grant was generous enough for us to be independent to do that. Now it's changed. In the United Kingdom, to study medicine, a student will have to pay up to £9,000 a year, which would be about what, $12,000 a year. Nurses don't have to pay fees. Nurses get a grant. They get a scholarship of about £3,000 a year, about $5,000 a year to support them. So they're not involved in paying tuition fees. But for nurses, that's not enough money to survive on in the United Kingdom. So a lot of our nurse students also do jobs. So they do part-time jobs and do their nurse training.
Oh, that's a lot.
But another problem we have in the United Kingdom is that there is no commitment for a doctor graduating from a British medical school to stay within the United Kingdom. And a lot of people go abroad. And they will go and work in New Zealand or Australia. They will go to places where there's more sun and there's maybe a better kind of life-work mix than they might get in the United Kingdom.
Oh, that's something to seriously consider changing, because I know when Tobias went on for his perio specialization, a number of students from Saudi Arabia were in the program, and the Saudi government did the same thing. They had their tuition paid for. They had a housing allowance to take care of their rent and food and survival. They got allowance to have a car, so they had reliable transportation to and from. But the catch was, when they went home, I forget how many years it was, but for so many years, they were not allowed to open a private practice or go into private practice. They had to work in the community clinics, which were in areas of high poverty. So it was their way of paying back the tuition.
Back. Absolutely, yes. Absolutely, yes. Another thing in the United Kingdom is the number of university places to study medicine. And what our universities have become over the last 20 years, they've become much more business orientated, and they know that they can charge higher tuition fees for students that they bring from overseas. And so quite a few slots that would be used to train our own people to be graduates and to work in the United Kingdom are given to people who come overseas who will pay hefty fees to train here.
Do they end up, just out of curiosity, do they end up staying, or does it look nice on their resume and they go back home?
It varies a lot. I mean, it does vary a lot. Quite a few will stay. Quite a few will stay, yes. But I think the majority probably go home. Yeah.
No, that sounds about right. So here in the US, I think we were talking about this already, but here in the US, it is a struggle at times to find a good doctor. If you have a chronic illness, it took 2 appeals in over 6 months just to get the okay to see my neurologist. Are the same things happening on a global level?
I think I don't know on a global level. I know certainly, and I think one of the contacts you have with the Democratic Republic of the Congo, where there is and I certainly have a colleague of mine who now works in southern Sudan, where he basically is the only person seeing people with epilepsy over a huge population. So in a lot of the world, I think there probably is no choice. You are lucky if there is somebody with a specific interest in epilepsy for you to see. In the United Kingdom, as I mentioned earlier, you get referred to the epilepsy service. You don't get referred to a specific consultant. And the person you see at the epilepsy service may not be the same person that you see the next time you go back, which again comes back to my comment on continuity of care. What we do have in Scotland, certainly, is a very good record linkage system. So if you move from one part of Scotland to the other, your scans, your medical records, everything is immediately available to the person seeing you. So they don't have to send away for your notes, or you don't have to tell your story all over again. Your documentation is always available wherever you are and whoever you see.
Which is good, because over here we have to request to send things over, and over the years I can't tell you how many times doctors haven't sent things over to a new specialist, and I'm telling my story over and over again. And one of the biggest frustrations, and it's one thing I've been fiercely advocating for, not just myself, but educating our supporters and people in the community. When I was younger, a lot of doctors would refuse to share test results with you. So even when doctors ask me, well, what was the result of this and what did they say? A lot of times the answer was, I don't know. They refused to show me the MRI. They refused to show me the EEG or my blood work. I was just told everything's fine, continue your treatment. And I think because of that, it creates a great frustration for the, doctors seeing new patients, and it's pretty much starting all over again and having to schedule tests where I think it creates a lot of unnecessary costs for the system.
Absolutely. I mean, a personal example, my wife recently went to a doctor at the pain clinic, and they were able to get up her records in a completely different hospital where she'd attended before, and say, oh, you had a bone density scan in 2002, and Isabel couldn't even remember that, but they were able to put the scan up on the screen and go over it. And then they were able to look at the MRI scans over about 10 years and compare the changes that happened over that time, because everything was available at their fingertips. And that's a tremendous advantage.
Oh, absolutely. Because if you didn't have that, no comparison, or, I'm not a doctor, but I'm thinking if I could see how a patient would be progressing, it would give me a better idea of what treatment round I would take for that patient.
Yes.
And it wouldn't be a guessing game.
I mean, this is such a change from when I started, where you would see people in the clinic and people often wouldn't remember what anticonvulsants they had been on in the past, or they would know them by a different name, which was often a problem. And you would maybe be in a situation where you're prescribing a drug that had already been prescribed 8-10 years ago. To have the information at your fingertips, that doesn't happen anymore.
Oh, no, that's the truth. And I mean, even myself being on so many different medications, I remember a lot from my, it's kind of ironic. I remember a lot from my childhood, but my mid-20s, when I was changing a lot of things, particularly when I was battling real bad depression, I can't even remember all the
Mhm.
stuff. And it was
Yes.
seeing my new neurologist. I had to let him know, I'm like, this is, I'm trying to remember this to the best of my ability. These are the medicines I know didn't work well. And this is what, every time they put me back on carbamazepine, this just seemed like the miracle drug, like the one that had to work for me. So
Mhm.
thankfully with mind controlled, he really didn't have to adjust anything. It's been more just continuing the maintenance, but it is very difficult, especially since I started being treated at the age of 2 and not having access to
Yes.
those records,
Absolutely.
trying to
Absolutely.
remember what the neurologist did 41 years ago when this
Yes.
first
Yes.
started.
Yes. Yes. Yes.
But here in the States, preventive care has not been a priority for many years. More people are starting to focus on preventive care due to the high cost of health care. What can patients do to help them maintain a good quality of life as they age, especially if they have a condition like epilepsy?
One of the things that I think came out of the States, and I can't remember the name, I met a lady from, I think it was from California, who'd been involved in the early development of self-management programs. And to my mind, there's no doubt that in all aspects of medicine, people living with a long-term condition, self-management has a major role to play. When I spoke to this lady, it was very interesting because I asked her about people who enrolled on self-management programs, and she said, well, they're nearly all women. Men don't seem to really, for some reason, I suppose, men often are more hesitant about talking to people and analyzing strategies. And so it was interesting that the majority of people that took up self-management programs, and here we were talking about I think it was arthritis, and it was MS, the two management programs that she was involved in. And the majority of people attending these self-management programs and being instructed in them were women. Yeah.
I think a lot of it has to do with culture over here. This is a very male dominated culture where men are expected to be leaders and
Mm,
providers and show by example. And a lot of times when they become sick, I think they worry about looking weak. And that's
mm,
so unfair to them because, at times when we have a setback, at least my opinion, to become stronger, it's okay to say I need help.
yes,
There's no
yes,
shame in
yes,
it.
yes,
Where
yes.
myself as a woman, I find in the healthcare system, not all doctors, but some doctors have looked at me like, just take a step back, don't worry about it. And it's like,
Mm,
no, I have to worry about it
yes,
because,
yes,
you
yes.
know, what if my husband were to pass or something, my health were to
Mhm.
get worse? I have to be ready to take responsibility for myself. And that's why over the years, things like exercise and eating better and, you know, I've gone back and forth with psychotherapy, doing cognitive therapy right
Mm,
now. I've just been frustrated with this system. So what I've done, rather than talking to somebody, I keep a journal to see how I am daily. And then a few days a week I do abstract painting. I found videos online where you could follow with the teacher and learn techniques. And I found that to be very calming and helping
yes,
in care.
yes.
So it's little tools you have to make up your mind.
Mhm.
How am I gonna keep this under control? How am I gonna feel balanced? And a lot of times it's really comes down to self-empowerment. You have to make up your mind that
Yes.
you're gonna be better and you're not gonna just, I've told so many people, I said, you cannot expect doctors to be magicians or gods. They're
Mhm.
human like you and I, and they can only do so much. It can't be the doctor snaps his fingers and the problem's solved. It
Mm,
has to be a team effort. You have to, when you walk out of the doctor's office, not only follow their orders, but things that they may not, get a grasp of. I mean, I also have PTSD, and talking to my neurologist about it, he understands and empathizes, but I don't think he really knows what to do to help me with managing
yes,
it.
yes,
So
yes.
I have to tell him this is what I'm doing and these are the results I'm having. And he's more there for support to make sure that, all right, I'm setting my goals so that stress won't trigger a seizure on me.
Mhm, mhm. I think again, part of the self-management is what you and the foundation provide, and that's information, and not just provide information, but I think also people learn through looking at organizations like yours that they're not on their own, that this is a journey that so many people share, so many people experience, and yet many people are very reticent to talk about or to come together, because there is, with epilepsy, and I know this personally, there is this wish to maybe keep it under wraps, to not tell too many people, and say organizations like yours provide information that tell people that they're not alone and instruct them in things that are important to know and to think about. And that's a very big contribution. So many of the epilepsy charities do this, and I think they do provide a lot of help and a lot of support. Again, there's often a reluctance for people to come and join charities as part of maybe, again, this wish to keep knowledge of their condition to themselves, to conceal, if you like. I know certainly our local epilepsy, our national epilepsy charity in Scotland has a very small proportion of membership in proportion to the total numbers of people in Scotland who are known to have epilepsy. We have, from our population of about 5.5 million, I think we have between 45 and 55,000 people with epilepsy.
Wow.
But the actual numbers who attend societies, join charities, and take part in charity activities is relatively small.
Yeah. No, and it's the same here. And I think a lot of it is fear of being discriminated against.
Yes.
And one thing I've started this year working with my local chamber, I'm slowly creating a DEI program. One of the frustrations I've had here in also working in social justice, talking to a number of people who are fiercely advocating for people of color and LGBTQ to have better rights and everything. I said, it's wonderful. I also advocate for those communities. I go, but you're missing something in your program. And they go, well, what's that? I go, people with disabilities and differences.
Yes.
I said, there's too many people who live in fear of that. What if someone finds out? What if I lose my job? What if I can't get my care? What if they're petrified they're going to end up homeless. And I was at one point, one of them, I just thought, if the wrong person finds out I have seizures, I lose my job. At that time, my medicine would have been $1,000 out of pocket. That was more than my monthly income. I would have been homeless. I would have been done. It would have been a death sentence. And I think that's what keeps so many people from wanting to come forward. It's just fear, and also having so many trust issues with trauma they've been through.
Yes, absolutely, yeah.
But medication costs have always been high here in the United States, putting many at financial risk or worse. Are these protections in the NHS system, or I should say, are there protections in the NHS system to help keep costs down for patients?
There are. It's complicated. Again, to get back to our National Health Service, everybody is entitled to treatment, but there are hurdles for that treatment before it gets approved. The first hurdle is a drug has to go through the regulatory authority. And once it's passed by the regulatory authority on the basis of clinical trials to show that it's an effective drug, then that drug then goes to an organization called the National Institute for Clinical Excellence, NICE. A NICE look at the drug from the point of view not just of efficacy, but of cost effectiveness. Is this a drug that our health service can afford? And of course, one of the problems is that many of the new drugs for cancer, in terms of the relative increase in life expectancy and the relative increase in quality of life, is maybe not regarded as reflecting value for money, if one has to use that expression, when you look at the cost of the drug. So the more expensive a drug it is, the more difficult it is for it to clear the hurdle of whether it can go onto the National Health Service list of prescribable drugs. If that authority says, yes, this is a drug that is value for money, there is another hurdle to clear, and that is that we have different health boards throughout the United Kingdom. Scotland has 14 different health boards, and I think it's 11 different health boards. And those 11 different health boards may have different funding issues and different priorities. So they may say, yes, this expensive new drug for epilepsy has been approved by the regulatory authority, approved by NICE, and it's come to our local health board, but in truth, we can't afford it because we've got to have our priorities here.
Yeah.
So you can have a drug that is approved in, say, Edinburgh, but not approved in Glasgow. And we call this postcode prescribing, where there is access to medication varies throughout the country. Now, in the days of the new drugs for multiple sclerosis that were very expensive, people would actually move house. They would relocate so they could get to a part of the country where the drug was available. So we do have hurdles. It's not plain sailing. It doesn't, because we have a National Health Service, doesn't guarantee that an effective drug will be available.
No, and that's astounding. I just wonder, out of curiosity, do they cap prices in the United Kingdom when it comes to medications? Because I not sadly here they don't. It's based on free market, but over where my in-laws are, they are not allowed. They're only allowed to charge to a certain percentage of profit before the German government will cap it. And one thing they're very strict on is they watch doctors very closely for what kind of medicine they're prescribing, how much of it, and how many tests they're doing, because I can't remember how many years ago it was, there was a gentleman who was a primary physician who was abusing the social system and saying he ordered tests when he didn't, or was prescribing things when he wasn't, and was billing the government massive amounts of money. Well, he finally got caught, and not only did he have to pay all that money back, they suspended his license for life. They pretty much revoked it. And so, seeing it as an example, I wonder about other doctors. How do they react to things like that?
We don't have that kind of monitoring in the United Kingdom because the doctors ordering tests and prescribing drugs have no potential personal profit out of doing that. They're working within the National Health Service. So the doctor who over-prescribes or over-investigates is probably just not a good doctor, rather than somebody who's trying to make a lot of money. When it comes to negotiating the price of a drug, that again, and I don't know precisely how it's done now, but it used to be that our Department of Health would negotiate with the pharmaceutical company. And that price of the drug then would be the price of the drug throughout the whole United Kingdom. And as I said, whether it was prescribed or not would then depend upon local circumstances and the availability of local funding. So we don't have that individual scrutiny of the way that a doctor is practicing here. No. But I certainly know that remember a case a long time ago of a doctor in Australia who was prescribing hypertension drugs to everybody in his practice because he had some agreement with the drug company.
Oh,
that could never happen here. It could never happen. No.
Sadly, it does happen here, and it was the reason many years ago I left a doctor because she pulled me off of the medicine. I was on Tegretol at that time, and she pulled me off suddenly and tried to put me on Topamax, and I got extremely sick. And she was refusing to take me off of it, but that's at the time when Topamax was a tier 3 drug. So the company was getting massive amounts of money. It was one of the more higher costing drugs at the time. And a lot of doctors who were helping to push for it can get compensated for it. And I got so sick, I threatened to call the state of New York, the health board, the medical board, if she didn't switch my medicines back. And thankfully she took me seriously and did, and I recovered. But sadly, they're able to play a lot of those games over here. And that's, I think, I'm not saying all doctors like that. We have some wonderful doctors here, but sadly we have some doctors who do put profit over the care of their patients, sadly.
Yeah. No, that would be, as say, somebody working within the National Health Service, that would be very, very difficult. We do have, I mean, when I say we don't individually monitor doctors, we do have a system of revalidation where hospital doctors, primary care doctors are assessed and revalidated by their colleagues on a regular basis. And that would maybe look at their practice, what they're doing, and whether what they're doing is above the norm or below the norm. Yeah.
I find they do that a lot in the academic system when it comes to clinical care. My husband every year has to do first a personal assessment of the
Yes.
accomplishments he's had, where he finds his strengths, what he's trying to build on, and everything. He submits it to his supervisor. The supervisor has to look at it, either agree or disagree, and why he's making those decisions. It goes to the dean for review, and then the dean has to send it up the chain to the board. I don't know if it goes directly to the president, but there's someone who's above HR who manages the annual evaluations. But it's the same thing. I feel at times my husband and other professors are held to stricter standards than,
Yes.
let's say, someone who's in private practice.
Yes. 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 Yes.
But in my time as a patient advocate, I have found that many patients over here in the United States do not understand what their rights are. Are there similar problems in the United Kingdom?
I think in the United Kingdom, people have rights, but as you say, it's a question of knowing that you have rights. It's not very easy to navigate through our social services to find out what your entitlements are and what they are not. I mean, we have, for instance, universal credit, which is a way of paying people who are not in work through illness a certain amount of money. And that amount of money can be influenced by their rent, their living allowance, their food allowance, their heating allowance. But it's such a complex system that to find your way through it and to actually claim what you're entitled to claim is extremely difficult. We also have a system called self-managed support. I've forgotten the full title, but it is where you, if you are, say, somebody who is say you have an illness like multiple sclerosis and you are housebound and you are using a walking aid and you can't do a lot of things for yourself, then you can get this thing called self-directed support, where you are given a sum of money that then can be spent in the way that you wish, on the care that you wish. So you can employ a carer for 2 days a week or 3 days a week. The social services will assess what they think your requirements are, and they will base the grant that you get on their perception of your requirements. Again, it's a huge hurdle for people to clear. It's complicated. It's not easy to actually find out that you have these resources, these benefits, if you like, available to you. And there's an enormous amount of form filling to do to try and actually get them, which is often beyond the ability of a lot of people.
Oh,
And
absolutely.
of course, to do it, most of the application forms are online, so you have to have a computer to do it.
Do they offer sources such as what we call attorneys here, but over in the United Kingdom, they're solicitors, I believe, or barons?
There are solicitors, but there are also advocates. We have an
Okay.
independent advocacy service that is paid for by funding through the state. But the advocacy services in the United Kingdom will only advocate on behalf of children and mental health issues, and mental health issues including dementia. So people that there is no free advocacy for people with epilepsy unless they have an associated mental health problem.
Oh, wow. That's very, very difficult, especially with the complexities that epilepsy can bring.
Mm-hmm. Absolutely. Yeah. Yeah. I
Yeah.
think other things, we have rights that maybe you don't have in America, but patients actually, and again, not many people know, but you have access to your case records.
Mm-hmm.
Under freedom of information, you can not only see your case records, but if you find an inaccuracy in them, you can actually apply for that inaccuracy to be corrected.
Mm. And that's a
So,
necessity.
well, give an example. If, say, somebody has recorded a seizure at a time that when you actually say you're driving and you reapply for your driving license and your family doctor gives a report to say, no, you had a seizure 6 months ago. And you can then ask to see your records and you can say, no, that wasn't a seizure, that was something else. And you can ask if you can demonstrate that the entry is incorrect. You can have that entry corrected.
Yeah. It was a very, now more than ever, we are starting to get access to our case records through patient portal. And when I was a child, it was very hard. And I find the older generation of doctors still do not. I actually left my former neurologist before the one I'm with now because he refused to give me my test results from my MRI and EEG. And I just
Mhm.
had enough of doctors refusing to cooperate with me. And I had him send it to my current neurologist. And my current neurologist said, well, actually, let's toss it out and start fresh. He goes, here's the thing with the EEG he gave you. One person read and said it was normal. Another person said you had generalized epilepsy due to a birth defect. I
Mhm.
said,
Mhm.
no, I don't, I'd
Yeah.
never had epilepsy because of a birth defect. I had a traumatic brain injury. He goes, exactly. He goes, that's why we're going to toss it out. He goes, he probably didn't want
Right.
you to see how different the reading word was and you doubting his capability of taking care of this.
Mhm. Mhm.
And it's secrets like that to lead to such levels of mistrust. It
Yes.
really,
Yes. Yes.
really is. But I think where I get frustrated here in America is so many patients are afraid to advocate for themselves in fear of, well, if I make the doctor angry, he or she won't want to help me. If I get too assertive and I'm listed as difficult, if I have to leave, will another doctor even be willing to accept me? And I had was about beginning of COVID, I think it was in 2020. I met a mother through social media. She was trying to get help for her daughter, and she lived in Buffalo, New York, where I'm originally from. And the neurological clinic she took her daughter to, they didn't put, her daughter's seizures weren't controlled, and despite that, they put her with the nurse practitioner rather than having the neurologist being under his care until they could get under control. And the medication they had her on was, the side effects were just so terrible that she
Mhm.
stopped
Mhm.
taking her medicine cold turkey and went into status. It was really a horrible situation. And her
Yes.
mother
Yes.
was telling me when they went back to the clinic, instead of the nurse practitioner going, why would you do this? What is wrong? She tore into her. She told her off, like, how dare you think you can do that? And by the time the mother told me what she did, I said, okay, number one, that's patient abuse. She has no right to verbally abuse your daughter like that. I go, the first thing you need to do is file a grievance against her.
Mhm.
She should not be getting away with this behavior. And I go, number two, I said, why isn't she with the neurologist if she's this sick, if her seizures aren't controlled and the
Mhm.
side effects aren't that bad? Why hasn't the neurologist assessed her? And she
Mhm.
goes, they told me she didn't need it. I go, I'm telling you, if her seizures aren't controlled, she needs to talk to the doctor, have the doctor decide where to go from here. And her mother goes, I can do that. I said, of
Mhm.
course you can. You're her
Mhm.
caregiver.
Mhm.
She has the right to choose what provider she wants to see.
Mhm.
And she had no idea that
No
she had
idea.
this
No. No.
option. And I said, next time you call and make an appointment, I said, insist on seeing the neurologist. And if they give you a hard time, let them know you're going to contact the HMO. Because then,
Yes.
if
Yes.
the HMO finds out they're violating rules, they can get in trouble for it. And she got her daughter into the neurologist, and he made a couple changes and she's doing great now.
Mhm.
But I mean, it just shows how fatal or dangerous something can be if you're not with the right provider.
Absolutely. Yes. Yes. Absolutely.
What future do you see for healthcare systems, and what can patients do to protect themselves?
I think it comes down in the United Kingdom, it's coming down to affordability. What can we really truly afford? We're seeing a slow privatization of our National Health Service. It's being done subtly. Things are out. I mean, it started off, for instance, with things like the hospital cleaning services being outsourced, and then the hospital catering service being outsourced. And now we find a situation in primary care where, because there are so few family physicians and so many consultations are now being done online, virtual, that in England, a lot of the virtual consultations with primary care physicians have been outsourced to private companies. So we're seeing a gradual erosion. The National Health Service is a difficult thing to see surviving because of the increasing cost of healthcare. Drugs, surgical procedures. We were all living longer. In the United Kingdom, our longevity figures are actually beginning to drop. Life expectancy has actually dropped a little bit in the last 2 or 3 years. But I think the problem is maintaining this cost. And if we're moving into an era, for instance, of drugs for dementia, it's an irony, really, that the better medicine becomes at keeping us live longer, the greater the cost of social care at the end of the journey. And so it's this sort of paradox of wanting people to live as long as possible, but on the other hand, finding that longevity itself carries huge costs in terms of the proportion of the population who are not the working population anymore, who have to be supported by the working population through taxation. So many problems. I don't really see where our health service will be in 10 years' time. I think it'll be a lot less available to the average ordinary person.
And I see a lot of that over here. For a very long time. They've been trying to go for what would be called Medicare for all. Senator Bernie Sanders in Vermont has for many, many years been fighting for this, and it's been a losing battle because a number of the lobbyists in Washington, working with other politicians, are doing everything they can to stop it, because they know that if something like this were to go in place with having 350 million people here, there's no way they can continue to bill at the high cost they were. They know that regulations and caps would be put on costs of certain things to make it possible. And it's sad to say that greed has taken over, but it has. But we're at the point where we're one of the highest, the cost per patient is one of the highest in the world. And despite the cost, a lot of people do not get the health care they need. And I think myself, as someone battling epilepsy, and I worry about my greater risk of developing dementia because of having seizures in my temporal lobe, and it's had an effect on my hippocampus, as well as my one grandmother, she passed of dementia. I told my doctor, and I think he was a little upset with me with it, but I said, if I get to that point where I'm starting to have a poor quality of life, I really don't want to continue with treatment. That's at the point where I want to arrange hospice, and please let me go. If I don't know who I am anymore, I said, I don't, I know my sons would be there for me, but at the same time, if I'm that gone, that it would be like them having a child. I'm like, what quality of life is that for me? But I think of the physical, emotional, mental, financial burden it will create for my children. And that's the last thing I want to do.
Yes, absolutely. I think in the United Kingdom, I suppose you could look and say that the National Health Service is a tremendous concept, but it never saw the escalating costs of treatment and the development of so many new treatments. It never envisaged that at all. And is it sustainable? In the current way that it's designed, the answer, I think, has to be no. But I don't know what we're going to find to replace it or replace part of it. Yeah. And I think it is very worrying. Yes.
It is very much so. Is there anything else you would like to share with us today?
I think that's been a very negative way to end. Yes. I don't mean it to be negative. I think we always have to look in the hope of something positive. And I suppose for people with epilepsy, there are so many positives in terms of the drugs. When I started off, there were 3 drugs. That was all that there were. There was an EEG, and there were no other investigations. There were no epilepsy specialist nurses. So I suppose if we look at epilepsy and just remove it from the rest of what we've been saying, yeah, things have always moved in the right direction in terms of healthcare in the United Kingdom. And let's just hope that continues.
Yes, and I've seen the same thing here in the US. It used to be just EEGs. I think I didn't have an MRI for the first time till I was a teenager.
Mm, mm.
And now when I've done my research and talking to neurologists over here, seeing not just a simple EEG where I just have the wires and lie down at the hospital for an hour or two, or they'd have me go to sleep and see what activity I was going on when I was in a deep sleep. But hearing all about these what was it, one of the pediatric neurologists I was talking to described a stereo EEG to me.
Yes,
And
yes,
when
yes,
I
yeah.
heard about being able to go in through the skull and put the electrodes into specific areas of the
Mm, mm,
brain,
mm.
and I was like, if you had told me as a kid that someday doctors could do that to pinpoint specific seizure activity and see if surgery was possible,
I
I
know,
it would have gone over my head. I
I
wouldn't
know,
even know what to think
I
about
know,
it.
I know, I know, I know, I
So
know.
it's amazing. So I think research wise, medication wise, we are succeeding. It's been a slow battle, but we are getting there. And that's why I encourage patients so much to advocate for themselves, to educate themselves. And if something doesn't feel right, please don't be afraid to say something. And
Mhm.
I know
Absolutely.
within the where I have empathy for doctors here is really with the way our healthcare system is, they only have so much time that they can really spend with us. Unless they have a private practice where they can really set their own schedule, they're on a clock. And I think that's so
Mhm,
unfair to
mhm.
ask somebody to go in within 15, 20 minutes, diagnose, follow up, prescribe something, and run to
I
the
know,
next patient.
I know.
One, it burns them out, but
Mm,
then two, that's where a lot of the mistrust starts with patients. And I mean, it wasn't until I started talking to doctors and getting their side of the story that I really started to have empathy for doctors, because I will be honest, when that was happening in my life, I thought, why doesn't my doctor care? Why
mhm,
can't he take
mhm.
2 minutes just to hear what I have to say? And I think it came down to that it wasn't that they didn't want to, it's if they wanted to get what they needed done, it was just go, go, go,
Go,
and
go, go.
that's
That's
it.
absolutely right. Yes, absolutely right. Yes, yeah.
And I hope it's something in time our system will address so that we can work together as doctors and patients to improve our relationships and teamwork so that they have a better, more positive environment to work in and can
Mhm.
help patients improve their quality of life. I think it's going to be something where to succeed at it, we must come together. We can't look at ourselves as, oh, that he's the doctor, or they're just a patient.
Mhm,
We
mhm.
got to see that, it's going to take all of us to get the job done.
Yes, yes, yes.
Well, that is all the time we have for today. Again, I want to thank Ian for coming and taking part. To see the great work we are doing, please like our social media pages and subscribe to our YouTube channel. We invite you to visit our website at www.defeatingepilepsy.org to see how we are making a difference for the epilepsy community. Thank you for your support, and together we will defeat epilepsy. Take care.